Good afternoon, everyone. So I'm Ian Hall, I'm the Associate Dean for Conferences. I just want to say one thing about next year's conference. Next year's conference is in Edinburgh, and we'd be really delighted to hear from you if you've got a really good idea that you think would go really well at Congress and attract lots of people. So our call for suggestions opens on the 22nd of July, so please do send stuff in for next year. So it gives me great pleasure to introduce Professor Chris Ham. He's Chief Executive of the King's Fund, which, as I'm sure most people know, is the absolute go-to health policy think tank, and an amazing place. Lots of us will know because we've been on training there and that sort of thing, but they're really the go-to place for health policy. He's also Professor of Health Policy, or has been at Birmingham University. And not only that, he has the ear of the World Health Organization and the World Bank advising them about health and, of course, how important it is to the economy. He's also worked in the NHS. He's been non-executive director for the Heart of England Trust, so he's got his feet on the ground. So I'm delighted to introduce Professor Chris Ham, who's going to talk about sustaining and transforming the NHS. Thank you.
Well, first of all, thank you very much for inviting me. I'm delighted to be here. Thanks to Simon Wesley in particular for suggesting I come along and contribute to this international congress. I'm not a mental health expert, first and foremost. I'm going to talk about this theme of sustaining and transforming the NHS. I will, though, have some examples from mental health to illustrate what I want to say in the next half hour. I guess the referendum and Brexit is at the top of most people's minds. I'm not going to talk in detail about that, but just to give you a preview, this afternoon we're putting on the King's Fund website a short briefing on what we think are the 5 big issues that now need to be addressed. And none of this will surprise you. The first is what it means for NHS staffing. How do we retain EU staff working in the NHS today, value them and recruit more in future? Second, what does it mean for patients and people who want to seek access to care either as tourists or indeed in other capacities in the EU? Regulation is the third issue. What does it mean, for example, for the working time directive? If we come out, will there be a move to rescind that or use it differently? Fourthly, what about collaboration? We've heard this morning, quite rightly, from Paul Nurse about the concerns and the risks to the scientific community, accessing funds, but also being able to access the researchers we need here, and vice versa. And then the fifth, perhaps the most important, if the economy is affected by the referendum result, this could have consequences for funding for the NHS and indeed for social care. George Osborne has already said, post the referendum, he expects there to be an emergency budget in the autumn with implications for tax increases and perhaps even more public spending cuts. And we think that would be the most important risk to be aware of as we move forward. So on that depressing note, let me move into the theme I've been asked to speak about. This is a really busy slide. You don't need the detail. It's drawn from the research of the Commonwealth Fund, which is a sister foundation based in New York. They do regular surveys to assess which country has the best performing healthcare system. And this slide from a couple of years ago suggests that the UK comes out number 1, looking at access to care, quality, spending, health outcomes, and so on, compared with, you can see the flags there, Australia, New Zealand, the States, Canada, and other developed countries. So really, really good news, except more recently, the OECD did a similar comparison and reached a very different conclusion. As you can see from the headlines there, they suggest that we now have one of the worst healthcare systems, if you believe the headline from the Independent. So different interpretations of where we are within the UK. This slide from Ipsos Mori suggests rising levels of concern among the public about the future of the NHS. You can see some of the detail there. A majority of the public concerned think that standards of healthcare and access to care might get worse, not better, going forward. That's the context for what I want to say, and three headings. And they're these, the big challenges. The first one is, how can we, the royal we, sustain existing services and standards of care at a time of so much financial pressure, increased demand, and the challenge within the NHS of addressing that. Secondly, how do we develop new and better models of care, much more integrated, much more care closer to home? And then thirdly, how do we deliver improvements in value through changes in clinical practice, if I can bring it closer to home for you? So I want to speak briefly about those three challenges in the time I have available today. Sustaining existing services covers the issues I've listed here. Partly it is about balancing budgets because of the deficits which are growing within the NHS in England today. But above all, it's about making sure that quality of care, patient safety remain paramount and they're not compromised by measures to reduce deficits and bring those budgets back into balance. It's about keeping waiting times short. We're so much better today than we were 10, 15 years ago. Wouldn't it be a tragedy if we went back to these very long waiting times of that time? Workforce of the future. We know there are gaps we have among doctors, nurses, other clinicians. We rely on recruitment from other countries, including within the EU. Will that become more difficult in future? And of course, social care, close cousin of the NHS, real cuts in social care budgets. 400,000 fewer people today get access to publicly funded social care than was the case back in 2009, 2010, because local government has had little option but to do that. So a lot of challenges here around sustaining existing services. My colleague, Helen Gilbert, did a study which we published not long ago, looking specifically at the area of interest to you in particular. What is going on in relation to mental health care? It was a review of board papers and interviews with leaders in mental health around the NHS in England. I think it will paint a familiar picture to you because you're out there in the thick of it, and it shows the growing pressures on beds, on staff, on services, the challenges around getting local access and the rise of out-of-area placements for some people with mental health needs. And of course, budgets have been constrained much more in mental health than they have, say, in acute hospital services. So mental health in many ways epitomises the challenges we have today on money and on performance. The second area is how do we develop new care models better suited to changing demographics, more older people in the population, the changing disease burden with long-term conditions and multi-morbidity and frailty both becoming increasingly important. This is the 5-year forward view from Simon Stevens and from national bodies within the English NHS. And the way I've simplified what's in the 5-year forward view is around what I've called these design principles. If you cut through the detail, what it's trying to do is say we need, yet again, to take prevention seriously. We must support people to live well and manage their medical conditions, expert patients being one example of that. It's about sustaining and improving primary care. The RCGP, the BMA have been very vocal about the dangers currently facing general practice, workforce funding and increased demand from patients. I think the key principle though is the last one within the 5-year forward view. How do we move away from fragmented to integrated care, integrated at all levels and migrating towards what we would call in our work population health systems? This diagram illustrates simply what that might mean. You think about individuals, and then you think about populations above, think about care services, and you think about prevention and health improvement. All of these quadrants are important and they should coexist. We should get rapid access to high quality care as individuals when we need that. But increasingly we're trying to make every contact count by building in advice to patients on behaviours and lifestyles to help them remain healthy. At the population level, really encouraged in our work at the Fund by how much progress is being made in some parts of the country to integrate care. And that's primary and secondary health and social care, and I'll come on to talk about physical and mental health. And there is real progress there, and I'm delighted personally because it's been a personal passion of mine for a long time to make the argument for integrated care, not fragmented care. But the bigger prize as well is migrating towards population health systems where prevention, health improvement is built into that, especially with local government having a much bigger role with the wider set of responsibilities that councils have working with the NHS to bring that perspective in. In these new care models, we've argued in this report, and by the way, all of the King's Fund reports you can access freely on our website to read online or to download if that's easier for you. In this report, led by Catherine Foote and colleagues, we looked at lots of examples, practical examples, of how people, patients, are being involved in their own health and care. Because the new care models we need are not the old paternalistic ones, they're much more patient-centred and patient-oriented, where people genuinely are partners in decisions about their own care. We need a new model too for general practice. If there is a crisis, it's not about shoring up our existing corner shop model of general practice, if I can be colloquial about it. It's about migrating towards a future which we can see already exists in some places, of practices collaborating in networks and federations, using technology to support people to access care, and engaging with others to deliver integrated out-of-hospital services. So yes, general practice, but not as we know it, working hand in hand with the community nursing services, with mental health services, and with a range of hospital-based specialists who we believe should be increasingly working alongside, not separate from, the primary healthcare teams. And in this report, we set out what that might look like. What will be a new model for the commissioning and funding of general practice in what we call family care networks, these federations and networks I've been describing. So what does it mean then, moving on, for hospital-based specialists? Again, a model not as we know it today, but one that we believe will be fit for the future. For many specialists, there are opportunities to work across hospitals and the community. I don't need to tell you that because I guess many of you already do so. And we found 6 examples, not including psychiatry, where this is already happening within the English NHS. And the point here is, while I'm a great advocate for integrated care, I don't mean organisational integration and mergers, I mean clinical integration, where clinical teams working alongside each other around the needs of patients and the populations they jointly serve. And that is what the 5-year forward view is creating opportunities for. This is the report we wrote. We found examples in the care of older people. In Leeds, Eileen Burns, geriatrician there, with a foot in the hospital, but an even bigger foot working outside the hospital, supporting the GP practices to deliver more routine care and providing much more accessible specialist advice and support with her team. Paediatrics in West London, a similar example. Dermatology was a third example. Diabetes, the work of Arthur Carr down in Hampshire, around Portsmouth being fourth. We looked at rheumatology in North London, and there's a 6th example which I've forgotten for the time being. The point is, all of these examples illustrate the future. It already exists, but as the man said, it's just not equitably distributed around the country. But go to these examples, read the report, and see what it might mean for how we can transform the relationship between specialist teams and primary healthcare teams. This is particularly important for the care of older people, given that so much demand and need arises from the growing numbers of people aged 65 and over. And my colleague David Oliver, previously National Clinical Director for Older People Services, has written a great report for us, showing what's happening again in different parts of England. There are some examples from Wales, Scotland and Northern Ireland as well, of on-the-ground integrated health and social care focus on older people's care. And I often say, and I mean it, if we can get care right for older people, almost everything else that we do within the NHS in particular will become relatively easy because of the volume of need and demand that the NHS and social care to meet. David and colleagues wrote this report, which has, as I say, very practical advice and examples of what is already happening that we need to generalise and roll out. And then on to physical and mental health integration. Chris Naylor is the colleague of mine in the fund who specialises in these issues. With a long list of other colleagues, he wrote this report we published only a couple of months ago now, illustrating what integration could and should mean in practice. And there are 10 priority areas that they identified in the report. I've listed them there. I'm not going to go through them, but you can access much more detail in what Chris and colleagues have done. And I'm sure many of you already are involved in work of this kind, and indeed some of your experience may well be represented in the research that Chris and colleagues did and is reflected in our report. Let me move on then to the third theme I want to address. The challenge of delivering what Simon Stevens has described as £22 billion of improvements in care, efficiency savings. These are not cuts, because the budget for the NHS, at least on current plans, will increase in cash terms between now and the end of this Parliament. When I talk about 22 billion, and when Simon does that, he's talking about the money we need to release from the NHS budget to reinvest in general practice, in mental health, to deliver parity of esteem, to improve patient care, and to improve the experience of staff working within the NHS. Patrick Carter's report enumerated many different ways, and I've listed them there, but we think the focus needs to be not so much on these areas. Yes, they are important, we can't ignore them. We think the focus should be on changes in clinical practice. And that's what we argued for in the report on the left, and the one on the right is a very short version for time for readers to get a sense of where we think the biggest opportunities are. And we focus on changes in clinical practice for one very simple reason. It's the myriad clinical decisions taken every day in surgeries, in clinics, in wards, in other settings about how to treat patients that add up to the £120 billion a year we spend on the NHS. It's not Jeremy Hunt and Simon Stevens and the finance directors who make those decisions. It's clinicians, it's treatment decisions about prescribing, about referral, about ordering of tests, about admission, about discharge, and so on. And unless we can begin to shape and change and improve those clinical decisions, there's no hope of delivering those £22 billion of improvements in care that will release resources to reinvest in mental health and the other priority areas. And that's not just a conceptual argument, it's based on evidence and fact. So very quickly, 3 examples from the past my colleague John Appleby worked on in the report. Look at what's happened around generic prescribing, largely by GPs. A big increase over that period of time. And if that increase had not happened, we would have needed to spend in 2013 about £7 billion more than was the case because of the additional cost of branded products. That is not a trivial sum of money. And that change in prescribing didn't happen through diktat from government, it happened through changes within the profession itself. Second example is cutting the average time patients have visited hospital stay in hospital. That has progressively come down, some people would say too far. And what you can see on this slide, the bottom right-hand corner, is if that hadn't have happened, we would have needed 10,000 more hospital beds to deliver the same volume of care. An improvement in efficiency, again, driven by clinicians themselves. And John's third example, similar but different, is look at the increase in day surgery and work done as day cases within the English NHS over that period of time. Without that increase, the bottom right-hand side again, the budget would have paid for 1.3 million fewer episodes of care than was the case if we hadn't have made that shift in the direction of day cases and day surgery. So here's the evidence as to why changes in clinical practice must be at the heart of any efforts to improve value, improve patient care and release resources. So the exam question is, what are today's contemporary examples of that? And what we suggested following an approach that I think was originally set up by the Institute of Medicine in the States about 15, 16 years ago, is this divides into three big buckets. The first is we've got to tackle over-treatment. Too much medicine is bad for patients and it's bad for population health. Not my view alone. BMJ has written about this, the Academy of Medical Royal Colleges and many others besides. And there's a number that's been put on this, but perhaps $2 billion a year could be reinvested if we were able to move away from too much medicine. The flip side is we know there is underuse of effective care, and that results in less than optimal patient outcomes. Here are some examples, and if we were able to tackle that, we might again deliver better care and potentially release some resources. If we're not providing effective care, which is evidence-based in a timely and standardised way, we're probably storing up more need and demand for the future, which will be more expensive and more complex to resolve. And of course, harm and errors, misuse. We are not unique. The evidence that I've seen suggests broadly the level of harm and errors across healthcare systems are pretty much the same everywhere. Sadly, medication errors, falls of patients in hospital, and you can think of other examples besides. So, three areas of overuse, underuse, and misuse of care, following on from the IOM typology. Much of this then comes down to the unwarranted variations in how care is delivered around the country. The Atlas of Variation has documented this in some detail using routinely available NHS data. The document on the right, getting it right first time, has come from recent work led by Tim Briggs, an orthopaedic surgeon now working in the Department of Health, brought in by the government to lead a programme of work in exactly this area of how do we improve and change clinical practice to deliver better value for the population. So the agenda I'm outlining here means that everybody has a part to play. We've inverted the pyramid, if you will. First and foremost, clinical teams. That's where these key decisions that commit resources start and where we need to influence most. Providers in the community, in hospital, in the integrated care organisations, of course. Thinking about how integration itself can reduce waste, handoffs and delays, say around delayed transfers of care. Commissioners must play their part, national bodies. Let me say a word about patients and the public and how they can be involved. We published this paper about 3 or 4 years ago now, written by Al Mully and his colleagues, about shared decision-making. Patient preferences matter. And the subtitle, Stop the Silent Misdiagnosis. If we don't share in decisions with patients, if we don't explain not just the benefits of intervention, but the risks of intervention, so if people really are partners in decision-making, then there is the risk of a silent misdiagnosis. A risk that if doctor or nurse knows best and they take the decision unilaterally, patients receive the care they may not have chosen themselves if they understood as much as the clinician delivering that care. And Al illustrates that in relation to treatment of breast cancer and treatment of prostate cancer. There are many other examples too. The Choosing Wisely initiative follows directly on from this kind of work on why patient preferences matter. I know the college is involved in choosing wisely. In fact, I was chatting to one of your colleagues over lunch about the 5 areas of care that have been identified to work on to make sure that patient preferences are known and are acted on, so care is much more evidence-based. Coming to the end. So what does this mean practically? It's all very well to have these highfalutin ideas. What needs to be done to support the NHS to improve value? This is quality improvement, putting it very simply. Every NHS organisation needs to have a method for improving care. Staff need to be supported with time and training. Operational efficiency of the kind I'm describing isn't very sexy or glamorous, but it's absolutely essential. Mayo Clinic alone, I understand, employs 350 system engineers. I think if you ask most people who work in the NHS, they wouldn't have a clue what a system engineer is, but they're people who can help clinical teams look at patient flow and improve that. The NHS, in our view, needs to give much more priority to these ideas. I wrote this paper with John Berwick from the IHI and Jennifer Dixon that we published in February this year, setting out the rationale in some detail for what this might mean. Again, if you're interested, please have a look at that on our website. There are some really good mental health examples of where this is already happening. One very close to here, and one that I had the privilege of visiting in the northeast a couple of months ago, the Tees, Est and Weir Valleys NHS Foundation Trust. Organisations that are both doing what I've described in relation to their mental health services, being able to demonstrate this is good for patients, it releases resources, and their stories from a mental health point of view are very, very powerful in echoing what you see in the acute services that have also been working in this agenda. This is my penultimate slide. It's a slide that takes us back to why does all of this matter from the point of view of the public. I hope you can see that. It's not work we've done, it's ipsos mori, asking people what matters to you, what things as a citizen would you say make you most proud to be British. And the good news is that the NHS is number one, and it usually is number one when these surveys are done on a regular basis. So take a photograph, tweet it around to the world, tell your friends and colleagues the good news about the NHS being so highly valued by the public and by patients, people who need healthcare. You'll be amused by some of the other items on that list, I'm sure, but pleased by the fact that the NHS comes out number one. I wanted to finish on this slide because in these really hard and challenging times, post the referendum, with the funding pressures, if politicians even have a thought about undermining the NHS by cutting budgets or moving to a different model of healthcare that's less equitable, less based on the principles that we hold dear, I hope they will pause and understand the value that all of us, whether we work in the NHS and or use it, or citizens who are just reassured to know it's there for us when we require it, how much we value the NHS in the way that this survey and other work suggests. And I think that's a reassuring defence for us, given the quite gloomy position I think we've been in for at least a week now around the referendum results, speaking personally, and also the challenges around money and performance. So thank you again, Ian and Simon, for inviting me. I'd be pleased to join you for this occasion. I hope that makes some sense from somebody who isn't a mental health expert by any means. Thank you.
Thank you very much, Chris. It certainly sounds like the King's Fund is a good friend of the NHS, and it's great to hear these ideas about how we can help to improve it and make it even better. We don't have questions for this plenary, but let's thank Chris again for marvellous presentation.